the slide, ma'am.
Yes, please. So you can go to the next one. So this is the framework that I'll be taking on. Next, please. So as I was sharing that this is an antibiotic resistance is a silent pandemic, which is a global threat, and it's really going to cost a huge in terms of morbidity, mortality, and also on the global economy. Next, please. And that's the reason that there has been a global and an action plan which has been devised for AMR containment, and it has it spans across many verticals, starting from awareness, understanding to collaborations between government and the global bodies. And our hospitals remain one small cog in the wheel because there are many other aspects of antimicrobial resistance, and that's why all of them have been brought together under one umbrella term of One Health, because we understand that antimicrobials are not just used in the hospitals and the healthcare, but they span across a gamut of industries like animals, agriculture, so on and so forth. Next, please. So when we talk about the stewardship programs in the hospital, the core components have been given by many of these professional organizations, and this is the one which has been given by WHO, which is more or less the same as has been advocated by other agencies like ITSA and CDC and so on and so forth. And it majorly talks about 6 core components, the most important and crucial being the leadership commitment. Now, it starts from there, and after that, there needs to be accountability and responsibilities fixed for people to carry on the activities. We need to define the AMS actions. It has to be backed up with education and training. And needless to say, for understanding the effectiveness of the program, there has to be a continuous monitoring, surveillance, reporting, and feedback. So they say that a hospital needs to have the 6 components, and they need to work around that if they have to make the programs effective. Next, please. So the question remains, they are very fine, but where do I make that start? Next, please. So in that sense, the accreditation bodies like NABH, which is the national accreditation body, and certain international ones like JCI, they do put forward certain standards. For example, the slide depicts the standard for accreditation for antimicrobial stewardship programs, which is depicted in their hospital infection control chapter, 3rd standard, and it talks about the commitment, which says that the appropriate antimicrobial usage policy is established and documented by the organization. Now, see, for accreditation, everything is about what you're going to do. You have to document that, and once you've documented that, you have to do it in that fashion. So that's how it works. And when we look at this standard, it does specify further that what does the organization need to have. They can have these guidelines for empirical therapy of identified clinical conditions. It also needs to specify the escalation, de-escalation process, as well as the duration of therapy. The organization needs to have a live antibiogram, and they need to use this antibiogram to develop the policy. And one also needs to identify and document what are the restricted antimicrobials that are defined in the organization. Now, the second core standard of NABH recommends that the organization now implements the antimicrobial usage policy and monitors the rational use of antimicrobial agent. And here they further specify that there needs to be a mechanism to monitor the antimicrobials as per policy. There also needs to be a mechanism of ordering and reviewing of restricted antimicrobials, and then it has to be backed up with the feedback and a corrective and preventive actions, wherever required. So the organization therefore implements an antimicrobial stewardship program is what they're looking at, and it's expected that the organization will create either an SOP or a program to address all these points. Next, please. When we look at the JCI standards, which is an international accreditation, they also talk about under their medication and management use chapter. And the standard says that the hospital develops and implements a program for the prudent use of antibiotics based on the principles of antibiotic stewardship. And the measurable elements for the standard says that the hospital needs to have a program which completely describes your activities and includes your infection prevention control professionals, physicians, nurses, pharmacists, trainees, patients, and even families too. This program is based on scientific evidence, and it includes the guidelines for the optimal use of antibiotic therapy for treatment of infections, including the surgical prophylaxis. Also, they say there's a mechanism to oversee the program, and the effectiveness of the stewardship program is monitored. So essentially, both these standards and both these accreditations, they're saying the same thing. Next, please. So now let's look at the establishment of ASME program in hospitals. What is the framework for that? Next, please. So when we talk about the framework of AMSP, I have essentially categorized to 3 verticals, how you should look into it. And we, as any quality improvement or quality processes, we divide them into structure, process, and outcome, which means that for any function to deliver, first of all, we need to create a structure, we need to define the processes, and having followed those processes, we need to monitor their outcomes. So for antimicrobial stewardship, in terms of structure, we basically talk of 2 very important components. One is the human resource component, which means the force or the people who are going to work towards it. And majorly it comprises of a committee, which is a multidisciplinary committee, what we call as AMSP committee. And then the people on ground who are going to work is the AMS team. And then, of course, we have the champions who are advocating the stewardship activities. And under the structure also, we also include the documents which are the guiding principles basis which you're going to take your program forward. And most important of them, as I mentioned earlier, which the accreditation bodies also looked into, is the AMS program. And which basically you are going to write your entire program into it as to what the roles and responsibilities are, what is the area, what is the focus area, what is the scope of the program, who does what. So these all have to be specified, and then you need to detail it further in other documents. For example, one of the important things that is listed in your MS program is that the organization will have an antimicrobial policy. And this policy will be then used to determine the prescription of antimicrobials and to monitor them. In terms of documents, it also requires us to create an antibiogram. And the minimal frequency is that at least an annual revision of the antibiogram has to be done based upon your data obtained that particular year. And you also need to have a formulary for antimicrobials where you define what all antimicrobials can come in your organization. So these are the framework, the structure that we have to put in to take our program forward. Having done that, now comes what you need to do in terms of monitoring how we are using our antimicrobials. And therefore, many things are listed under that, which conforms to the standards, which means that you need to look into your surveillance of antimicrobial use, of resistance, of the restriction practices, what is the compliance to the policy that you have defined in terms of how well they are being followed, or what are the gaps. And it also looks into some activities that you do, like audit and feedback, timeouts, and cultures. Are you sending cultures before you put the antimicrobials? Now, once you start following this process, the logical conclusion is that it would lead to certain kind of outcome, which needs to be again measured, because all these good activities will definitely result in some improvement somewhere. And how we measure is that we look into probably the antimicrobial consumption. And this is something we cannot do on a monthly basis because it's a little time consuming unless you have a software for it. So therefore, probably you do once in 6 months, and we do it once in a year when we look at the complete antimicrobial consumption, days of therapy, MDRO rate per 1,000 patient days, the drug resistance index. And another thing that you would like to monitor is your hospital acquired infections, whether it has impacted the infections in any way. So these are some of the framework that we often talk about, and the entire program is now going to rally around this. Next, please. So as I talked about the structure of this program, the manpower and the policies, and this is the kind of structure most of the healthcare organizations would have. It starts from the top. The hospital always has a medical director, and therefore, under the guidance of medical director, we constitute the Antimicrobial Stewardship Committee, and under which we have a core group. Now, remember that medical director's role is extremely important. So therefore, the engagement of the leadership for this program is very, very crucial, because he's the one who's going to sanction the budget, provide you the resources in terms of manpower. In case some investment in diagnostics is required, that is where he comes into the picture. So our engaged medical director is a huge plus point for the program. The second important thing is the Antimicrobial Stewardship Committee, which is basically an advisory group, and looking into the program. They provide the guidance, they review the policy and the treatment guidelines, they provide the direction to the program, and of course they have this periodic meetings where they take a call on the various actions taken. On the ground, it's the core group, which is the what we call as a task force, which is the one who's working at the bedside, and they are the ones who are responsible for the audits, feedbacks, education awareness, etc. on ground. So this is the mechanism to oversee, support, and govern the program, which is one of the accreditation requirements. Having said that, all the organization may also have a board, and the board actually puts in the governance mechanism also, because that's independent of the hospital, and they can again, provide whether we are going in the right direction or not. Needless to say, all these antimicrobial stewardship activities have to be backed up by a robust infection prevention and control committee and the control team. Next, please. So as I was talking about the core group, these are the movers and shakers, and in the minimum, they would comprise of an ID physician, and in the absence of ID physician, it could be an internist with a special interest in infectious diseases, very, very crucial to the program. You also need to have an intensivist, because they're the great champions for these stewardship activities. They are the maximal users of the antimicrobials in the unit. They are the go-to people for many of these critical care issues, and therefore it's good to have an intensivist on your team. And in case the intensivist can be a friend of yours, it makes things that much more easier. The pharmacist and the pharmacologist are actually the game changer for this program, and they are the ones who really can take the program to the next level. The microbiologist and nurse leader, again, are a very, very important component. The only thing, I mean, it's not necessary that all of these people are in board. Even 2 or 3 committed people, they can make a start, right? The basic requirement is that they need to be passionate about the cause, they need to be committed. And having said that, their role and responsibilities also need to be clearly defined in your program or the standard operative procedure. Next, please. So I have just put down a few responsibilities of the core team. The physician and the ID physician is basically into the consultation dialogue. He's an influencer, he or she is an influencer with respect to the usage of antimicrobials. And we often see that when the cases are fine, nobody consults. But the moment there's a little complication is when the expertise is actually looked into. Many of the hospitals have a very good process where all the antimicrobials are reviewed by a team of ID physicians. But for that, we need a good number of people working in this field. Good to know that people are now opting up for this specialty and are being sought also. The clinical champion or the intensivist, as I said, he's the greatest advocate. He should lead by example. And when these people, these champions implement it in their own domains, acting as a role model, it creates a positive ripple effect, because very often these stewardship activities are very difficult to start with. So you have to start small. You have to start experimenting in one unit and take that success, scale it up to the others. So therefore, it's very, very important to have a good, interested clinician champion on board. A pharmacist, as I said, would be responsible for the audits and the prescription reviews. The pharmacologist is again, collaborating with pharmacist and is responsible for various kinds of analytics. Is a convener of the SP committee, and they're also responsible for communications with respect to alerts and errors. The microbiologist, we all know, would responsible for running a quality assured lab, generating antibiograms, and the alerts and outbreaks notification. Nurse is again a very, very important component of the stewardship activities. Besides focusing on the infection control parameters and the advocacy, they can also be engaged for many other activities of the stewardship program. Sending cultures is a very important component of a good antimicrobial practice. And many a times we see that they often get missed or they're not being ordered properly. So again, this is one area they can really help us out. Next, please. So this is the responsibility of the committees and the core team. I've already elucidated that. Important thing is that at least the committee should meet at regular frequency. You can define as per your organization need. It could be from once a month to once a quarter, whatever works for you. However, the core team needs to meet more frequently. And in our hospital, we had defined the frequency as once a week to fortnight for the core team, and at least once in 2 months to begin with for the antibiotic stewardship committee, and whatever they do, it has to be minuted again, because this is again required from the accreditation standards. Next, please. So this was the structure, the manpower part of it. The second part of the structure is the guiding documents that you need to have in place. These are the 4 or 5 things you must definitely have. As I said, there needs to be a program which defines your entire roadmap, talking about the goals, the scope, the role and responsibility. So basically, whatever I just spoke, it has to be documented. You need to also mention what are going to be the program content of the stewardship activities in your hospital. You need to define the measurables. You need to talk about how often are you going to measure them, how you're going to measure them. So basically, whatever you're going to be doing is what you're going to be writing here. The second important aspect of these documents is the AMS policy. And most of the hospitals would have this policy, and ICMR actually also came out with a guiding document. And using that, you can create a policy of your own department on your organization also, and in the minimum it should contain these 6 or 7 points that I've mentioned. What are the tenets of good antimicrobial prescriptions? How do you collect samples for culture? How do you categorize patients? Surgical prophylaxis guidelines, the treatment of empirical treatment of infections, categorization of restriction of antimicrobials, doses, dilution protocols, etc. So basically, it's your go-to document for any kind of prescription, especially for where you're looking at the empirical management of patients. Antibiogram is a very important component, so is organization formulary, and you need to back up with many surveillance forms or performers where you're going to capture the information for analysis and presentation later on. As I said, ICMR, WH has got very good documents. You can use this for your reference. If you do not have a antibiogram, the expectation is that you do create one, or you can refer to the laid down guidelines from the ICMR or any of such regional antibiograms that may be available in that region. Next, please. The MSP program, just a word of it, sometimes it gets confusing, these programs and policies. So program is a big overarching document which broadly specifies, and other than purpose, scope, responsibility, the program content needs to include the surveillance, what you're going to be looking into. For example, it could be compliance to the process metrics for empirical prescription, irrational combinations, de-escalation. It also describes how you're going to engage with your clinicians, the education part of it, and the audit. So this is what basically a program should include, and this needs to be reviewed at least once in a year or once in 2 years. Next, please. And this is a typical example of a policy. The content, PG has got one beautiful one. We also have our own policies. So basically, you can include whatever you want. They are not very. It's not very prescriptive, and it's a good idea to start small and then build upon it. Next, please. Now, important thing for all of us to understand is how do you create these documents, and the important thing and the good thing that works is if you have a participative manner, which means that you create a team which is motivated, which is enthusiastic, which has energetic people who want to make a difference, have these reference documents, and taking them as a backdrop, create a template document for your own organization. As I said, start small and keep adding to it. When we made our own policy, we only put surgical prophylaxis into it. We didn't talk about empirical management at all because we knew that it was a very big, field, and we needed some experience before we could go on to that. Having said that, when you're creating these documents, identify chapter champions. For example, if you're creating surgical prophylaxis for, let's say, cardiac surgery department, you include 2 or 3 people into it, make one champion, give this draft documents to them, have a buy-in from them, have a discussion, run the existing documents to the expert team, and then freeze the documents. And when you have them as an authorized signatory, the implementation may become a little more easier. There's no guarantee about that, because we've often heard about the IQ effect. It says that people place high value in things they had to build or create. So when we have this participative mode of creating documents, it becomes a tad easier to talk about them when you are going into the specifics. But having said that, it's no guarantee, because it's another thing, one thing to create the document, another one to follow it up, as we have seen in our own experience. Next, please. So once you have created this document, you have created this policy, and it need not be perfect, because you will build upon it. One has to build upon it as we go forward. Make it widely available and visible. You create booklets or posters, or put it in the hospital intranet or on the mobile app, whatever resources that you have available at your end. Make good use of them and put them across, so that there is a ready availability and accessibility to these documents. We in our hospital have put it on the screen of all the computers of our hospital, so you can access it from anywhere. And we have a hospital intranet system, so everybody can access this particular documents on the computer itself. Next, please. But and while you've done that, it's very important to do some baseline audit also basis the policy, because seeing is believing. You need to have your own data as to where you are. So you may conduct a point preference study. You can actually just do 1 day or 2 day studies looking into how many patients are on antimicrobials, how many patients are on more than 3 drugs for 3 days, how many of them were irrational combinations, patients where appropriate cultures were sent. So you can look at whatever you're wanting to look at. You can do a point prevalence study on that. You can also look at your own surgical prophylaxis pattern basis the 3 tenets of prescription, which is dose, the time of administration, the choice of agent, and the duration of therapy, and present that in a kind of a traffic light pattern, the reds and the yellows and the greens, because they have a very good way of capturing the attention. So once you have this, you have a policy, you have some baseline data. Next, please. You now present it to your team. You have to, get your clinicians on board, and it's a good idea to engage your leadership and call all the stakeholders, the opinion makers, the key leaders for this particular meeting. Show the data, make it visible, and you'll be surprised sometimes. What feeling you have about your own practices, and when you actually compare it to the data which is there on grounds. So once you've done that, it's important to set some goals, and as I said, data is a very, very powerful tool for change. Seeing is believing. Sometimes we don't believe what we are doing until it is shown to us in a very objective manner. So make it a big song and dance about it, make it a big event, because stewardship activities need to attract that kind of attention from everybody. Next, please. So now you've done that. You've created a framework, you've created a policy, you have people who are doing things, you have done a preliminary audit also. So now you need to take the program further, which means surveillance has to start. And before that, you have to have a clear goal as to what you're measuring, what you're monitoring, and what you're aiming to achieve. So you could already have some idea with the help of baseline audit that you have done. Next, please. So you define the measurables for the antimicrobial stewardship activities, and we define them under 2 headings. One is the process metrics, and the other is the outcome metrics. So processes where you're going to be working on, and the simplest, let's say, because it's so easily understood, I'm really going on and on about surgical prophylaxis, because it's well defined, and there are not too many deviations to it, and the patient's conditions more often than not do not come into picture. So for example, you can define that I'm going to be looking into my own surgical prophylaxis with respect to all those 3 or 4 parameters. I would also like to monitor what is the compliance to process for restricted antimicrobials. In case a process was not existing, you create the process and then you start monitoring it. You could also look at, the evidence-based, practices when the cultures are available, so whether they are being de-escalated or not. And you can also look at cultures before antimicrobials if they were sent. So these are some of the process metrics. You can define what you want to do basis your own experience and basis your own program. Having said that, once the process metrics are defined, you also need to monitor them with respect to the outcome metrics, and they probably may not come into this slide because it's PDF. I had animated that. So it will basically comprise of the antimicrobial consumption, the days of therapy, the drug resistance index, which I had already initially mentioned. So this is how you monitor your stewardship program as you go forward. Next, please. So this is all very well. Now is the actual journey what you be taking on, which is quite challenging to begin with. So it's not about what you do, it's about how you do it. For implementation, as I said, you need to be going slow, stepwise manner. Don't take more than what you can do. You can actually start from 1 unit only instead of starting from the entire organization. Pick up the low-hanging fruit, right? Where with minimal effort you can have maximal output. Build on the existing structure, maximize teamwork, and champions are extremely critical. So you need to excite a few people, get them on your side to help you out when we start this journey. Next, please. So as I said, for antimicrobial prescription, basically, if we can divide it very broadly, it's about surgical management and medical management. So low-hanging fruit I talked about, you can pick up surgical prophylaxis, and you can choose the 3 or 4 specialties. You needn't choose all of them. Pick up the services which have the maximal number of surgeries, and you can start from there. Look into the components of prophylaxis, meaning choice, duration, redosing, and stoppage of antibiotics. They are very well defined. You have also put them into your policy. You've also given education. You've also made people aware that this is what we need to be doing. Now start monitoring it. Next, please. So this is how you do it. You need to put some targets, and you need to have very smart goals. And by smart, I mean they need to be specific, they need to be measurable, achievable, relevant, and time bound. If you're going to put unrealistic goals, you're never going to reach there, and it's going to cause a lot of disappointment and setbacks. So for surgical prophylaxis, based upon your own baseline data, point in putting a target of 80%. You can simply say that, okay, if we are now at 20, we would go to 50% in 6 months. So you decide basis upon the momentum of your own organization, and you also identify the champions, the leads who are going to be taking it forward. So similarly, for time of administration, this is the lowest hanging rest with the anesthesia doctor who's going to be giving this drug at the time of surgical incision. And same is the case with doses and redosing. Now, stoppage of SP is again a challenging area, and here you would require a lot of dialogue and engagements, and it is just sometimes one step back and once forward and two backwards. But having said that, you have to work on that. So this is one aspect of it. The second component, for example, of your program could be let me look at how many cultures are being sent before the antimicrobials, right? Before the administration of antimicrobials. And if your experience is not good, probably you can take that as initiative, and you can engage your nurse leaders for the same, and you can put again a target that, let's say, in 3 months, 6 months, 8 months, whatever works for you, I'm going to be more than 90%. So what I'm trying to say here is that your targets need to be well defined and in a certain time frame. Having said that, it's not necessary that you may reach there. Next, please. Yeah, and the other low-hanging fruits from the antibiotic policy could be, redundant therapy, or the duration, or the IV to oral switch, or the dose optimization. So these are the ones which are not questioning the clinician's authority on prescribing antimicrobials, and therefore they're easy to deliver. And here the role of pharmacists is very, very critical during their daily rounding of prescription audits and feedbacks. They can give this feedback to the doctors, and in our experience, we have seen that it is very well taken by the clinicians. Many times they need the help with these doses and the rational combinations and all. So one can start from that and start monitoring. And this is again a very, very important aspect of stewardship activities. Next, please. So the cornerstone of our program, any quality improvement program or initiative remains rests on 3 factors. It's a robust data collection, and the data collection again needs to be standardized with the help of certain tools, and the people who are collecting the data also need to be trained on that. Then we need to feed it back to the stakeholders and clinicians, and just feeding it back is not good enough. Sometimes we need to plan certain interventions also. And these interventions can be simply a dialogue or a training or putting in a process like stop orders or a restriction process. So whatever works for you is what we need to identify. And then it also talks about fixing accountability for change where required, be it at the individual level or at the leadership level or at the system level. For example, for many of us, this is all about, a lot of it is a manual collection of data. And if somehow we can systematize it, it would really be very, very helpful. So it's again the responsibility of the leader of the hospital to provide these kind of resources to be able to do, so that all of us can perform to their maximum. Next, please. So this is again, then you need to define the frequency of these audits or whatever you're doing. You can do these point prevalence studies an alternate month or once a month. You can look at the de-escalation process on an ongoing basis, then prospective audits, various specialty guidelines where you're going to monitor. Again, you define, the methodology, the frequency, the methodology, and the responsibility. So once you have this audit calendar, the things become very, very systematic, and you are also not likely to drop out things that are relevant and important. Next, please. So having done that, now you've got a framework, you are meeting regularly, you're feeding it back to the clinicians, you have put some processes in place. The next step is you need to assess your program also, because it's not just good enough to keep on doing things unless we are doing as we planned. It doesn't work. So then comes the performance assessment of the program. Next, please. So this is, for example, you're looking at the justification forms. Now, this is your organization has defined that these are the restricted antimicrobials. And once you prescribe them, then you need to give a justification form, and you can design the justification form as you deem fit. There are many such examples available. And then you track their compliance, whether the clinicians are mindful enough of, giving rationally for the prescription of these restricted antimicrobials. Excuse me. And in case you find that it's not up to the mark, let's say you put up a target of 80%, 90%, and you are somewhere at 33% where we were in 2021, and that is the time we need to do a PDSA cycle. We need to understand why it's not being filled. We need to talk to the clinicians, what are their challenges, and then put in certain measures for improvement. For example, a greater engagement of pharmacists or the AMS team with the clinicians, ready availability or accessibility of these forms, because the forms are not available, the clinicians are not going to look for it. And they also need to make sure that the nurses are aware of this program, of the protocol, so that they can make these forms readily accessible. And needless to say, a clinician awareness and engagement is also important. So whatever you're doing, there has to be a science and method to it, and it's not just a collection of data, because if you're not going to use that data for improvement, better not collect it. So it's a sheer waste of time for everybody. Next, please. Similarly, a de-escalation data, where you actually look into the lab reports and see how many of them have been de-escalated. And I know it's a very challenging field, because the patient is either doing well or not doing well, and yes, especially in the complexity of a patient care, sometimes it's not easy. But we have found that these feedbacks sometimes are important. When you're actually telling the reports to the clinicians, they do kind of take cognizance of it. And in our experience, for example, if the de-escalation on its own was happening in about 21% of cases with this prompt from the MS team, an additional 34% could be brought into the loop, taking the total de-escalation percentage as per the lab reports to a healthy 57%. So it does work, but yes, it requires a lot of engagement, active engagement, and gaining the trust and confidence of the clinicians. Next, please. Similarly, another thing that you can look for is the percentage of patients who are on 3 antimicrobial agents for more than 3 days. So very rarely would there be a situation for a patients to require 3 antimicrobials after a period of 3 days, when you have kind of zeroed down on the tentative diagnosis. So again, this could be one of the parameters that you would like to monitor. And in case there's a challenge, again, you need to identify which services, which clinician, is this something that can be done in terms of providing better diagnostics or better support. This is what we need to look. Next, please. And as I said, culture of cultures, very, very simple thing to do. Target is more than 80% compliance. If it's not working, why is it not working? Look at the way they are collecting the cultures, put in some education sessions, nursing, the skill-based training. And when we do that, we've seen a steady increase in compliance. And trainings and good sample collection for cultures for nursing and residents is a very, very important thing, and must not be ignored when we are running an antimicrobial stewardship program. Next, please. Another thing, surgical prophylaxis we talked about, right? So this is one of our orthopedic service, the joint replacement surgery. And if we see that we are pretty good in almost all the other parameters, but the stoppage of 48 hours that our policy talks about, it actually is, in many centers 24 hours, but earlier we're giving antimicrobials for about 10 days. From 10 days, we've come down to 72 hours, and now we want to bring it down to the 48 hours. So this is a scaling down. You cannot expect a clinician who is used to giving antibiotics for 7 days, 10 days, to simply tell them that stop at 24 and 48 hours. It's not going to happen. So, we did it in a phased manner, but now there is a lockjam at 48 hours. So we've not been able to make a headway here. And this is where we need to do another quality improvement initiative. We need to find some trade-offs with the clinician as to what are the factors, because many times it's so many other fears that range in a clinician's mind, and we need to address these fears, be it the practices in the OR, the C. Next, please. And finally, as I said, you need to have your annual goals, and once you have fixed your goals, you need to measure them also and see whether you did well or you need to do something more on that. So you could define these AMS goals in your annual program, and it could be related to your structure, process, and outcomes. Put everything out there. Make the targets a little tough, because too easy targets, again, that could generate a sense of complacency. But anyways, make them realistic, because it's a new field for many of us, and it takes some experience to actually reach this level. Thank you. Next, please. And this is again, excuse me, this is a very interesting stewardship program assessment tool, which has been laid out by WHO. Very, very comprehensive tool. You can use this tool periodically to assess this program. Now, we make use of this tool every year during the Antibiotic Awareness Week to see where we are with respect to our program, and any challenges, any shortfalls which are there, you can take them up for improvement. Next, please. So to summarize, I mean, it's a long journey, cannot be summarized in just about a few slides. But the key ingredient for a successful stewardship program is the commitment, and a commitment of one person, two people are also sometimes good enough to start the fire. And leadership is extremely important, and for optimizing and to start this program. The commitment has to be backed by actions, so policies and practice. There has to be a good number of assessments and tools in place. Then you have to have tracking and reporting. And needless to say, the education has to be there on a continuous basis. In most of the organizations, we have a very high attrition rates. People come and go, and therefore a lot of focus has to be there on the education and expertise. Not only that, we need to take it out in the community also. Each hospital needs to have some kind of awareness built into it. It's, the community awareness built into its own program, because it's not just about your hospital. You need to raise the awareness, amongst all around in the community as well. So this is one cause where we need to join hands from every possible area that we can. So this was a small snapshot of the journey as we took it. I may have missed many points. It may appear very simplistic, but trust me, it's not. It has taken a lot of years for us to reach where we are, and still we are not where we would like us to.